Hi, good afternoon. It's John Snyder here for another edition of Newton-Wellesley Medical Group Lunch and Learn on this glorious sunny Thursday. We're really happy to have Dr. Brian Eisner on the spot today talking to us about surgery for urolithiasis and an evidence-based approach. Next slide, Brian, please. Teasing upcoming Lunch and Learns, we have Lumps and Bumps next week with Dr. Ellie Tomczyk, and then the following week we have Dr. Nora Fillington talking to us about inguinal pain. It's all about the history and physical exam. And then we have our repeat lecturer, Dr. Kavita Sitharaman, coming back to talk to us about CGM. Next slide, please. As you know, all of these talks are stored up on our intranet as well as up on YouTube just by searching Newton-Wellesley Medical Group Lunch and Learn. Just wanted to make everybody aware, I'm sure you are, that next week we're going to be celebrating Hospital Week and Nurses Week combined. You are what makes Newton-Wellesley Hospital special, so please feel free to get on to Newton-Wellesley, our intranet, Newton, which is www.nwh.org/intranet, to see a host schedule of fun events, some virtual, lots of free food in the cafeteria. So if you're on campus, please take advantage of that. Please let us know that you can click on schedule for our trivia hub and other fun activities. Next slide. Capping off the end of the week, we're going to invite everyone for a Saturday morning ride on Peloton. Please, as you know, we've been pushing our Peloton app program. If you're around Saturday morning, we're going to do a live ride at 8:30 a.m. It is a 30-minute classic rock ride, so I'm sure that'll appeal to most listeners and most riders. With Sam Yo, 30 minutes at 8:30 a.m. Please put that on your calendar. It'd be fun to ride with a whole bunch of colleagues, and don't forget to ride with the hashtag NWHstrong. Next slide. We also have our other physician and APP wellness programs, including our physician care concierge program, which you guys have heard me talk about on a weekly basis, our virtual meditation classes. We have online coaching and physical training still available. Please contact Daniel Destin at the Shipley Fitness Center, and our virtual yoga class. Don't forget the Peloton 1-year free membership for physicians and APPs is still available. That's 1 full year free. No obligation to you. All you need to do is contact Leland. You don't need a bike. You don't need a treadmill. All you need is a smartphone. Next slide. We want to remind folks about, as we move into spring and summer and those injuries after work and on the weekends, we have our Newton-Wellesley orthopedic walk-in. Avoid the emergency room. We have right there x-ray, casting, bracing. You can see we're open till 8 p.m. Monday to Friday and on Saturday and Sunday. It's walk-in or you can call ahead. Next slide. And here are the things that we treat there, as I've said. Next slide, all yours, Brian, I believe. Yes, I'll be quiet. Thanks very much for doing this. And if you guys have any questions for Dr. Eisner, please feel free to throw them in the chat box. We'll get to them at the end. Otherwise, enjoy the talk.
Well, thank you, John. It's really a pleasure to be here. And, you know, John, I'll just say that some of my friends tease me that I speak a little quickly. So I'll say that I certainly appreciated the efficiency in which you delivered those 7 slides. A lot of great information and a lot of great programs. So like any talk, here are just my disclosures that I want to reveal before the talk begins. And, you know, before starting, you know, I just want to say many of you I've met, many of you I haven't, but I'm thrilled to be here at Newton-Wellesley in my new role as Chief of Urology. I'm really excited to collaborate with the primary care physicians and primary care practices. And I think what we're looking for towards the future is to, number one, build on the great urology work that's already been done in Newton-Wellesley for decades, as well as really kind of continue to offer the gamut and sort of modern type procedures. And so, you know, we want to see every patient from the undifferentiated patient with this person may have a urology problem to the patient with the most detailed cancer or incontinence or kidney stone or BPH and everything in between. And so I certainly want to be a resource for the people on this Zoom for many of those things. You see my email and cell phone. That is a legitimate offer. 24/7. Call me anytime. Email me anytime. We're trying to, you know, grow urology to its fullest potential here, and whatever I can do to help shepherd that is my greatest pleasure and my job. So this is our team. Now, I want to be very clear that our MGH Urology Associates group has several docs that come to both campuses, as well as several docs that just remain on other campuses in Newton-Wellesley. But this is a group of people that you may see more and more frequently. They're the group of people that have surgical block time in Newton-Wellesley, meaning they perform some of their operations or the majority of their operations here. And you see that we sort of have a gamut. So just to kind of run through it real quick, myself, I focus on kidney stone disease, Doug Dahl, Adam Feldman, and Dimi Zlatev down here on the right focus on urologic cancer. Elise Day focuses on female voiding dysfunction and incontinence. Nobody has to write this down. We can get people this information. Martha Dyer and Matt Massacott focus on general urology, and Michelle Kim focuses on BPH and voiding dysfunction. So we're trying again to run the gamut of urologic care here. You know, we're really, really excited that all these folks have a strong on-campus presence. So to get into the talk, you know, I wanted to talk about evidence-based surgical treatment for kidney stones in 2021. I actually have this is what I focus on in my practice. I actually focus on both surgical and medical management. So I actually do a lot of 24-hour urines and stone prevention as well, and I'm very interested in that if anybody has patients for that kind of work. Some people traditionally went to nephrology for that, but I really have a strong interest and love working in that space too. So anybody interested, please let me know. But today we're going to talk about surgical treatment for the next 25 minutes, and I hope this is interesting. So we have a set of guidelines. There were 2 surgical stones guidelines published in 2016 describing 15 index patients, 12 adult, 12 pediatric, 1 pregnant. This is a massive undertaking. Some of my friends were on this panel, but in a way, perhaps some part of me would be glad I wasn't on it. They had to read 2,000 articles and distill them down to these short recommendations. So the goals for today are describe a guidelines-based approach, examine how the guidelines fit with modern literature, and also describe kind of then how we incorporate these into urologic practice. So I'm going to start with the patient with the obstructing ureteral stone. This may be the most sort of common stone emergency we've seen, or the most kind of common urgent patient we see at Newton-Wellesley in urology. So we see here that, you know, patients with uncomplicated ureteral stones can be offered observation. Now there's some caveats with that, but this is an example. This is a patient you see here with a stone kind of sitting in the lower ureter. I deliberately drew the stone to be something that looks like it may or may not pass. You know, it's not quite small enough to just shoot out the ureter. And so we know for patients that have an uncomplicated ureteral stone, we do offer them a trial of passage. Now, uncomplicated means they have to not have so much pain that they can't get out of the hospital, and of course not have a fever, urinary tract infection. And so we often offer them tamsulosin or a medical expulsive therapy with alpha blockers. And the reason why that works is that there are alpha receptors in the ureter, which mitigate contractions. And an inhibition of these contractions causes less peristalsis, less edema, and increases the passage rate. I enjoy giving this medication because I do think it helps, and the safety profile is very high. However, I do want to point out that for people with allergies, you know, I tell them, you don't have to worry, you know, hundreds of years ago, people passed kidney stones and didn't use Flomax. So it's not an absolute must, but it certainly gives some benefit. It's been debated as to who should get alpha blockers, and it's a continued topic of debate in our business. You know, one could argue that you may want to think about it in terms of stone size. So for the tiniest stones, maybe it's not worth it. Kind of 2 millimeter stones, these almost always pass. They rarely cause ER visits, may not be worth it. But once you start getting into 3, 4, 5 millimeter stones that have a lower passage rate and of course larger, you know, you may want to consider it. Again, it helps with the passage rate. So I personally, if someone calls me, I say give it to everybody who doesn't have an allergy. It's got a high safety margin, few side effects. It hastens the time to passage and may reduce symptoms of colic. So this is a little bit of it's the same stone, but a different presentation, right? This is one of the true urologic emergencies, right? When a patient presents with fever, flank pain, tachycardia, elevated white count, plus or minus hypotension, and ureteral obstruction, often by a stone. So basically a stone and pyelonephritis, we call this pus under pressure, right? So basically what happens is the infected urine sits up here in the kidney and the ureter, you know, where my mouse is. It cannot bypass the stone. There's a risk of pyelovenous backflow and those bacteria getting into the bloodstream and causing sepsis. And so this is a true emergency. What's very interesting is if you look at claims data, the mortality rate of someone presenting with urosepsis and a stone is actually 20%. That's a huge number. And the mortality rate with emergent decompression with a stent or nephrostomy drops down in half. So antibiotics are helpful, but for these patients, they really need emergent decompression. What I tend to do is if they just have a fever and aren't quite quote unquote septic, I'll ask the OR or the interventional radiologist that we should place a stent or nephrostomy within 4 hours. If they have hypotension or sepsis, I push this up to within 1 hour. And there's some data that early intervention really helps these patients in terms of their outcomes. The question is often asked whether we should place a nephrostomy or stent, and I will be the first person to tell you there's no right answer. There's a lot of things that drive this decision, and there's never been a great study that shows that one is better than the other. The one caveat to know is that in theory, when you place a ureteral stent, we do that by performing a cystoscopy, and then we have to pass a guide wire up the ureter past the stone into the kidney in order to place the stent. And so in theory, if the stone is very, very impacted in the ureter, there's a chance we won't be able to get that guide wire past the stone. On the other hand, when we place a nephrostomy tube, of course, that comes in through the flank, so there's no stone to bypass. And so, you know, I think the patients often prefer stents because they like to not have the bag draining their urine to, you know, externally. But there is a small but real risk of failure of the stent that shouldn't really exist because of in nephrostomy, because there's no stone to bypass. So one of the ways that we think about this is that there's obstructing stone and simply a fever. Let's just stent that patient, give them a chance. But if they're really going down the tubes and, you know, are septic, maybe we'll just put in a nephrostomy because, you know, it's a little more surefire. So this is what a ureteral stent looks like. We could talk about stent symptoms till the cows come home. I'm happy to discuss that later in the talk if you like. But the ureteral stent is what we call double J. It's got a coil in the kidney, a body down the ureter, and a coil in the bladder so that it is self-retaining. And then a nephrostomy tube comes in through the flank or retroperitoneum and has a coil into the kidney. So those are the two evidence-based things about ureteral stones I want to talk about. I now want to move on to surgical intervention. I'm sorry I'm talking a little bit quickly, but it's sort of like my entire surgical practice in 20 minutes. So there are three main surgical treatments, or what's called procedural treatments for kidney stones or ureteral stones. The first is shockwave lithotripsy. It is fantastic when it works, and I want to emphasize that because that is the big caveat. In the right patients, I still think this is the best procedure in urology because it turns a otherwise surgical procedure into something truly minimally invasive. However, you're going to see in a few slides, I'm going to show you there's some real good predictors of success and failure that we really need to think about before committing patients to this procedure. Ureteroscopy is either rigid or flexible endoscopy to laser and basket stones out of the ureter or the kidney. We can get anywhere in the urinary tract. There's a lot of overlap between people who are candidates for ureteroscopy and candidates for shockwave lithotripsy. And then there's some patients that are poor candidates for shockwave that should go right to ureteroscopy. And finally, percutaneous nephrolithotomy, which happens to be something that I sort of specialize in, although I sort of perform all these procedures. That's a percutaneous puncture through the flank, typically similar to a nephrostomy tube, but instead of putting a small bore tube in there, we put a large bore sheath in there. And this is really for the largest stones, you know, those big stones the size of a golf ball or a small piece of broccoli, like I just tried to describe to the patients. It's got the greatest risk, but of course it's the greatest reward because these stones tend to be stones that can literally wreck a kidney if we don't take them out promptly. These patients stay overnight, typically a day or two. And often these patients, not often, but many of these patients have associated infection. And so sometimes their hospital stays are a bit longer. So now I'm going to show you some quick examples of these. So again, shockwave lithotripsy, external shock waves are delivered by an energy source. So you lay on this table, you actually get sedation, not general anesthesia, but simply sedation. And then you see here's a therapy head, here's an x-ray head, and here's an ultrasound. And basically the ultrasound machine and therapy head are used to locate the stone. Sometimes we use fluoroscopy, although I have to say we have a very nice machine here, which we can use almost ultrasound exclusively. And we use that, we target the stones, we blast them, and then we get follow-up x-rays to see if it works. It's by far the least invasive. Many of these people could go to work the next day without much pain. But here's what's interesting. We know now that Hounsfield density on CAT scan, that's how bright the stone is measured on CAT scan. If it's over 1,000 Hounsfield units, those stones tend to fail shockwave. We also know that if you put larger patients in the shockwave machine, so people that have a larger stone to skin distance. So interestingly, it's not so much about BMI because people who carry their weight in front are actually okay. It's more the distance between the stone and the kidney through the flank. Sorry, excuse me, the stone and the skin through the flank. So a stone to skin distance larger than 10 centimeters also predicts failure. But to put it in perspective, many people with a BMI over 30, which is many of our patients, will have a stone to skin distance much longer than this. So again, for thin people whose stones aren't very hard, shockwave is fantastic. But we just need to be judicious to make sure we're not doing it in patients who are going to fail. And then finally, this procedure is contraindicated in patients with coagulopathy. So we do have to be careful. For me, because I can do ureteroscopy in patients who are on anticoagulation, if they're on anticoagulation, I shift them to ureteroscopy. That happens to be my practice. So ureteroscopy, that we sometimes abbreviate as URS, is a transurethral procedure. So it's done in the operating room under general anesthesia. and we place either a rigid or a flexible endoscope in the ureter or kidney and laser the stones. This is just a subtle distinction. We use a more rigid endoscope for the lower ureter, but we are able to get everywhere in the kidney and treat stones with the flexible ureteroscope. We laser the stones and we basket them. This often requires a postoperative ureteral stent. The patients don't like the stents. They cause a lot of urinary frequency. They cause some bladder symptoms. Please, 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 if your patients are calling you and complaining about their stents, please push that on to us. I know many, many fabulous primary care physicians who try to take this on, but I feel like you folks have so much else to worry about, and this is very much in our wheelhouse. So feel free to say, page your urologist if someone's complaining to you about their stent. I mean, we should really be owning this. There is a lot of data on meds that help this. We try and be opiate free. I use a lot of diclofenac, which is a potent anti-inflammatory. I use a lot of Flomax, which relaxes the bladder, the ureter, and a lot of anticholinergic, which relaxes the bladder. And that often does do the trick for these stents. But they do cause a lot of problems after surgery. Unfortunately, they're required after most surgery because they do help us combat the edema and any sort of bleeding or clots that happen after the ureteroscopy. So we do often leave them in for a week or two, sometimes less, but they're helpful for healing, but they bother the patients. And finally, one of the advantages of ureteroscopy over shockwave is it's not really limited by the things that limit shockwave, and it can be done in patients with coagulopathy. So there are many patients, either they're big or their stones are hard or they're coagulopathic or have liver disease. Those patients in my practice get shifted towards ureteroscopy because they're poor candidates for shockwave. And here you can see, I'm going to outline a hydronephrotic kidney. You got a lot of, backed up urine here, a little bit of a tortuous ureter to about a 1 centimeter stone in the mid-ureter. This has a low likelihood of passing, and so this patient would get ureteroscopy in my practice if they failed to pass that stone. And now I'm going to show you a video on the right-hand side of your screen. So the pink that you see is the ureter. I'm doing what's called a semi-rigid ureteroscopy. I'm going to pause it for a second. So I'm going to outline the pink is the lumen, or the wall of the ureter. This is just a guide wire that's sitting in the kidney to make sure I don't laser the ureter inadvertently. And here's the stone. And what you're going to see now is I'm going to use a contact laser. For those of you who are interested in physics, it's a holmium neodymium YAG laser. That red beam is the aiming beam for the laser. And you see I'm going to laser and fracture the stone without lasering the ureter. Sorry, there's a little bit of feedback on that image. And then in a minute, you're going to see the stone broken up into fragments. And then you'll see me pulling them out with a basket and dropping them in the bladder. Again, these ureteral stones typically range 2 to 10 millimeters. You see now I'm going to basket the stone right here. So there's a small basket. I'm going to grab the stone in my basket with my assistant here, capture the stone, and then I pull it out, drop it in the bladder, and I'll evacuate it from the bladder at the end of the case. And then we sort of keep repeating this process until the stone is out of the ureter. So now I'm dropping the stone in the bladder, and I'm going to go back into that ureter and go grab more stones. Again, laser fragmentation and basketing, and that is ureteroscopy in a nutshell. Percutaneous nephrolithotomy is for large renal stones. Again, this is something that I happen to get a lot of referrals for because not a lot of people do this procedure. A lot of people do ureteroscopy and shockwave, also which I do, but a lot of people don't do this one. So this tends to be for larger stones, again, sort of highest risk, highest reward. And so just to give you an example, here where you see this darkness here, that's a pyelogram, right? So that's contrast injection into the kidney. The kidney would be sort of where my mouse is kind of outlining, would be the parenchyma of the kidney. And here's a large stone that I marked. And what I do is I place a percutaneous puncture. It's very similar to how a nephrostomy is placed. I happen to do this procedure myself. I don't put in emergency nephrostomies. That is IR's domain, but I do this procedure myself in the operating room. So some urologists do it with interventional, but I just was trained in a way to do it myself. So, what we do is we put the patient to sleep, we perform a pyelogram, we puncture the kidney. You see now I have a guide wire that's going from the flank past the stone down the ureter. We then put a big dilating balloon in the kidney, inflate the balloon, you see the balloon there, and then we pass a sheath over the kidney and extract the balloon. So now what you see is I have a sheath right here. This is just a hollow plastic sheath. It's sitting right in the renal pelvis. You see my wire going through protecting it, and then you see I have a stone right here that I'm about to go in with a telescope and break. I then put a telescope that's called a nephroscope, and what we call a lithotrite, which is basically an ultrasonic stone breaker, and break the stones and pull them out. This is what it looks like schematized. So again, you have the kidney here. You have a large, I try to draw a large staghorn stone, way too big to pass, a few wires down the ureter, and this sheath that's going from the kidney, from the renal pelvis out of the skin, where I can then place my telescope and my drill and go in there and drill out the stone and extract the pieces. And this is what it looks like. So just to give you some perspective before I play the video, this blue rim here is the sheath. So my telescope's in the sheath. This green thing here is a wire. This pink stuff here is the lining of the renal pelvis. This metallic thing here is the ultrasonic probe. And what you're going to see in a moment is my telescope's going to enter the kidney. You see this large yellow stone right here. That's a stone about the size of a golf ball, to give you some perspective. And now I'm going to break the stone with my probe. You see some other just catheters and wires there. And then eventually I'll pull out the stone. Again, this is the highest risk. I'd say the biggest risk is transfusion. It's about 1 in 100, maybe 1 in 200. These are a little bit elevated numbers. This operation is all about the anatomy. As long as it's safe for the percutaneous puncture, we should be able to avoid all these things. But of course, if you do enough surgery, eventually you'll come upon a complication. But I certainly spend a lot of time being very diligent and trying to understand patients' anatomy. I use fluoroscopy and ultrasound to try and create my percutaneous tracts in the OR the same way the interventional radiologist would, to make sure as I tell the patients, hit the kidney and not the stone. Or sorry, hit the kidney and not the colon. And now I'm basketing those stones and pulling them out. So how do we decide between these procedures, right? So here's what's interesting, right? Every patient comes into my office and they say, I want shockwave, because they've Googled it and they realize it's the least invasive and it's the least painful. But it also doesn't work in everybody. And so I tend to be pretty deliberate. I like to use this triple D score that was developed by my colleagues down at Brown, my friends down at Brown, which takes into account basically the things I described to you before: the density, the distance of the stone to the skin, and also the dimensions, or how big the stone is. And you see they have a very nice predictive algorithm based on the patient characteristics as to where shockwave will work and where it won't. And I think if you're up in this area, if there's an 80% chance of working, maybe 70, I think that's great. If that's closer to 50 or 40, you may want to kind of offer the patients a different procedure. And so I give the patients real world estimates as to what I think my success is, and then I let them choose. We use shared decision making, but I say if they choose shockwave, they must accept the risk that it's going to fail. Couple other kind of guidelines and evidence-based sort of things to think about. So for renal stones that are symptomatic, it's interesting. The lower pole of the kidney versus the rest of the kidney have different outcomes. I don't expect you as primary care providers to, remember this or work on this, but these are things we think about. In the lower pole, the shockwave clearance is less, and so shockwave is used for smaller stones in the lower pole, whereas for larger stones greater than 1 centimeter, we tend not to offer it. And then in the rest of the kidney, we offer all these things under 2 centimeters, and then over 2 centimeters, we move to PCNL, as I described before. Again, for the larger stones, PCNL is first-line therapy for non-lower pole greater than 2 centimeters. For lower pole greater than 1 centimeter, either ureteroscopy or PCNL. And basically what I tell the patients that are deciding between ureteroscopy or PCNL is I say, you can have 2 procedures. It's hard to get all that stone out in 1 ureteroscopy. So if the stones are that big that I'm offering percutaneous, I say, it'll probably take me 2 ureteroscopies, but I'm happy to do that. It's less invasive, but you're going to have your stent for a couple weeks and have 2 procedures. Or I could do 1 PCNL, but here are the associated risks, and I let the patients choose. And of course, if they cannot come off their anticoagulants, so many of you will get an email from me at some time in our collaboration that'll say, can this patient safely hold their Plavix for a week? If not, no problem. And that's because if they can hold their Plavix, I will do PCNL, and if they can't, I will do ureteroscopy. So these are the kind of questions I ask to kind of get the patients the right treatment in the OR. Pregnant patients are a bit of an interesting group because this is different from when I was a resident. We used to just put a lot of stents in these patients and let them deliver. The difficult part about that is that these stents are very, very uncomfortable. First of all, they're uncomfortable in non-pregnant patients. They're very uncomfortable for the gravid uterus. These women are often urinating 2, 3, 4 times an hour. It can be very debilitating, especially in the 3rd trimester. The stents often encrust. And so we now know it is safe to do ureteroscopy with laser in these pregnant patients. What I actually do, this is just a series of it, which shows it can be done safely, a small series because there aren't really very many big series. But what we do is I tend to do it without even fluoro in the room. So for this one, I use no fluoroscopy. I just have the ultrasonography techs come in the room. They can confirm where I'm, in the kidney with my stent, but we do it all with direct vision and endoscopy and no fluoroscopy. I do warn patients there's a small risk of preterm labor, although that may actually, it's probably more likely due to the stone and the stress of the stone than the surgery itself. I also involved OB and MFM very closely because I like their advice, for managing these things that I'm less comfortable with in the pregnant patients. What if you do no treatment? So somebody once told me the best surgeons know when not to operate. I think that's important to know that, we don't always need to operate on every stone. This is interesting data from Olmsted County, the Mayo Clinic. So when you have a stone in your kidney, that is observed. And I observe many more stones than I operate on, but it's important to know and tell these patients the symptomatic event rate in 10 years is about 50-50, right? And so I think a lot of the counseling is based on size. If someone's got a small stone, I say, leave it be. What do you have to worry about? You'll likely pass it anyways, or it may stay in your kidney forever. But if someone has a centimeter stone, although you can still watch it, I think what I would say to them is 50-50 chance it comes out in the next 10 years. And that's a stone that's going to wind you up in the ER with the stent and then a ureteroscopy. So I will go after some of those patients electively if they ask me. I certainly don't make a habit of it. I'm happy to watch any stone that's not causing obstruction. But, it is important to know that there is an event rate of about 50-50 every 10 years. The other thing to know is stones in the ureter. If you leave them alone, even if they don't cause pain, silent hydronephrosis can kill a kidney. It's a kidney killer. And so ureteral stones are different from renal stones. I just got finished saying that for renal stones, I'm happy to observe them till the cows come home. But if someone has a stone in their ureter causing hydronephrosis, even if it's causing no pain, I tell them if it hasn't passed in 6 to 8 weeks, I like to take it out because there is a risk of silent obstruction and renal loss. And we know that starts to happen somewhere around the 2 to 3 month block. So basically what I do is I give patients a month and a half to pass their stones. If they haven't passed them confirmed by imaging, then I tell them it's time to do ureteroscopy so that they don't have kidney damage. And then we have a shared decision making. And I don't force them to do ureteroscopy, but I tell them the reason why it's time to consider that at 6 weeks is that we don't want someone to have silent hydronephrosis and lose any of their kidney function. I'm sorry, this doesn't project very well, but this is a little bit of formatting error. But this is just to say that for the largest stones, for staghorn stones, those, when we observe, the consequences are much greater. So there's a chronic renal failure and recurrent pyelonephritis and urosepsis in about 1/3 of those patients when observed long-term. And so for people with staghorn stones, especially recurrent infection, as long as we could get them to the OR safely and they're interested, I do try to treat them because they obviously have a lot greater consequences to no intervention. So I'm sorry that was a bit of a whirlwind tour, but I did make it a little bit in time, under my time budget. I'm so grateful for this opportunity. I'm grateful for the opportunity to be your chief of urology and to be sort of a go-between and shepherd for the future of urology at Newton-Wellesley Hospital. To summarize this, we have guidelines in 2021. We want to practice evidence-based medicine. We're better understanding how to minimize the complications of the sort of more invasive procedures and about the forefront of stone management. But I really am very blessed to have shockwave ureteroscopy and PCNL in my armamentarium so we can make evidence-based decisions and share decision-making and get the patients the best stone care that they can. This is my beautiful family. I couldn't do anything I do without their love and support. And my contact info for anybody who wants to reach me, 24/7 open offer. And I'll turn it back over to Jonathan. And again, I'm so thrilled for the opportunity to present. I'm sorry if I talked quickly.
Thanks, Brian. Appreciate it. There's a quick question in the chat box. The diameter of the uretoscope was the question of how big, how wide. Are they different sizes or one size? You're on mute now, Brian. There you go.
Excellent question, Jonathan. So this is one of the reasons why ureteroscopy has increased over the last 2 decades as shockwave has decreased, is that the scopes have become smaller. Yeah. So the current diameters we use are around 9 French or 3 millimeters, which fits in most people's ureters. But it's a very good question because one of the things for me that determines how long I leave a stent in, and that's really the patients don't even care about the surgery. They care about how long their stent's going to be in, right? When am I going to get that pain done? I already Googled the stent. And what I tell them is what decides how long the stent is in for me is how much dilation I have to do and stretching and manipulating of the ureter to get that scope in. So you can imagine, John and the group, that The scopes are 9 French, that fits in most people, but there's a variety of range in terms of the compliance and how narrow everybody's ureter is. That's also why sometimes I have to do some people twice, because sometimes I can't get that scope in on the first try. But most patients we can get it in, but it's about 3.5 millimeters in diameter.
Let me ask you another question, because I know there's a lot of primary care docs on the call. We get, a lot of calls, people have recurrent stones, and they call us and they're in a little bit of pain, and, we want to kind of conservatively manage them. I'm always a little worried that there's hydro going on. What's the ideal test as an outpatient if they don't have a fever, they're not sick, they just feel like they have another stone, for us to kind of rule that out in a safe way without much radiation or other exposure? Would you reach for an ultrasound, or would you do flat plate?
So it's interesting, John. So I think flat plate is a little bit kind of going away. I think partly because, there's a lot of stones, even calcium stones, which are the most visible. You can only see them about 70% of the time. It's also very, very contingent on body weight. So especially the bigger patients, not that great. What I would say is this, I totally get what you're saying. I've done a lot of work actually myself in trying to minimizing radiation. I'll start with CT because CT gives you the most info. I will say the good news is in the MGP system, there has been some tremendous radiology research, and we're really protocoling these stone protocol CT scans so that they're as low as a radiation dose as possible. And I'm really grateful to our radiology colleagues for really pushing the envelope. The other thing about it is that gives you very good info on stone size and location, which also predicts what's going to happen in the future. That said, I utilize ultrasound a ton. The nice thing about, so the downside to ultrasound is often all you'll get out of it is hydro versus no hydronephrosis. But I also argue that if there's no hydronephrosis and let's say no blood in the urine, you may want to look for a different diagnosis, right? And especially in, young women of childbearing age, especially in patients who've had a lot of radiation, and I'll say this, my follow-up practice is like 99% ultrasound because I'd rather reach for the ultrasound first. And then if I have questions, jump to CT for the reasons you stated, for cost, for radiation and whatnot. But that said, if you need an answer like this, or maybe it's an elderly patient or an overweight patient in whom perhaps the radiation isn't that big of a deal, just get a non-contrast CT scan.
Yeah, we would order it as CT stone protocol basically at our institution?
Totally.
All right. I don't see any other questions. You urologists must be good at that arcade game where you kind of grab the doll where, when it comes down the claw from, since you're grabbing all those stones out of the ureters.
John, it's funny. What I tell my patients, because they make that joke too, is I say, it's funny. My kids don't understand why they never win that game. And I said, but I will work as hard as I possibly can to win that game before we're done with your surgery. So it's a great analogy. I use it all the time. Luckily, I have better chance than my son does at winning that iPad out of that mountain, right?
Thanks a lot. Welcome to the Newton-Wellesley. I know you've been here for many years, but welcome to the chief physician. We're really happy to have you and your team here. And you've definitely given us your name and number, something to think about today. Thanks very much, everyone. Have a great weekend, and we'll see you all next Thursday for Lumps and Bumps. Thanks, Brian.